We're going to get started in just a moment. Welcome, everyone. Thanks for being with us. We're going to give our audience just another moment to filter in. Thank you for coming today. Well, hi, everyone, and welcome. I am Michael Morella, Managing Editor at US News and World Report. Thanks for being with us for today's webinar on managing the medically complex child. Our panel will explore some of the innovative work happening and the key challenges that remain to help improve care for some of the most vulnerable and challenging of young patients. Today's session is part of our special Pediatric Priorities virtual event series, where we explore what children's hospital executives, pediatric providers, community stakeholders, and parents can do to improve the well-being of America's young people. You can learn more about our program, our speakers, and our July sessions on vaccines and community partnerships at usnews.com/pediatric-priorities. We are recording video of the session today, and we'll be archiving that on usnews.com. We're also simulcasting on the US News Facebook, LinkedIn, and YouTube platforms. So now I'm very pleased to introduce our distinguished panel today. With us are Dr. Hilary Frankel, Assistant Professor of Pediatrics at Children's Hospital at Montefiore, who sees patients in the Linking Individual Needs of Children with Services Complex Care Program. Dr. Catherine Freundlich, Assistant Professor of Clinical Pediatrics at Vanderbilt University School of Medicine and Director of Family, Community, and Referring Network Engagement for the Program for Children with Medically Complex Needs at Monroe Carroll Jr. Children's Hospital. Dr. Rona Sonnabend, Division Chief of Pediatric Diabetes and Endocrinology and Associate Quality Officer for the Department of Pediatrics at Texas Children's Hospital, as well as Associate Professor of Pediatrics at Baylor College of Medicine. And Dr. Maggie Wright, a pediatrician with the Beacon Program at Children's Mercy Kansas City and Clinical Assistant Professor of Pediatrics at the University of Missouri Kansas City School of Medicine and University of Kansas School of Medicine. Welcome to you all. Thanks for being with us today. One final note, before I turn it over to our moderator, if you have questions, those of you in our audience during the panel discussion, we invite you to type them in to the Q&A feature in Zoom on your screen. We'll try to give voice to some of those as our time allows. Now I will turn the mic over to my colleague, Christine Comizio, Senior Health Editor at US News, to lead the discussion. Christine?
Thank you, Michael. Thanks to our audience for tuning into this discussion today, and a big welcome and thank you to our panelists for joining the conversation. First, I want to kick it off. We're going to hear from each of you. If you could each speak briefly about your background, areas of specialty, and your roles at your institution, particularly when it comes to children with medical complexities. Dr. Frankel, I'm going to kick it off with you.
Great, thank you for having me. I'm excited to be here. So I'm a general pediatrician at Montefiore, which is at the Children's Hospital at Montefiore in the Bronx, so in New York City. And I see patients in our LINKS complex care program. So we do general pediatrics for children with medical complexity. So it's primary care. We try to provide a comprehensive medical home for those children. And so really the focus is primary care, usual services, and then also care coordination, which I'm sure we'll get into more, but that's what I'm doing.
Thank you. And Dr. Freundlich, Freundlich, I'm going to turn it over to you.
Thank you also so much for having me. I'm really excited to be part of this panel, and thanks to everyone who's come to join us. I work as a complex care pediatrician at the Program for Children with Medically Complex Needs at Monroe Carroll Jr. Children's Hospital. It's in Nashville, Tennessee, and where I have worked since 2016, shortly after the program was founded in 2014. My work prior to this was in pediatric hospital medicine and general pediatric outpatient care. And in addition to my primarily clinical role, I also serve as the director for family, community, and referring network engagement for our program. So kind of specifically trying to connect to our community. And I also am fortunate to serve as the site lead for a health services research network called the Children and Youth with Special Healthcare Needs Network.
Thank you. And Dr. Sonnabend, I'm going to turn it over to you next.
Sure. Hi, everyone. What a pleasure to be here with this esteemed panel, but also with all of you in the audience. So I'm Rona Sonnabend. I am currently the chief of endocrinology here at Texas Children's Hospital. And on top of that, I have the pristine pleasure of also taking a large role in our quality infrastructure at Texas Children's and really driving complex care populations towards a population health focus with extensive data analytics and informatics platforms to really support interventions that really support predictive and prescriptive analytics for patient cares and improving health outcomes. So excited to share that with all of you as that comes up today's panel. Thank you.
Thank you. And finally, Dr. Wright.
Thank you so much. I'm so looking forward to this discussion today. I'm Maggie Wright. I'm a general pediatrician at Children's Mercy in Kansas City. So I provide primary care for children with medical complexity and their siblings. We have a multidisciplinary medical home model that aims to provide comprehensive evidence-based care in partnership with children and their families. Our program also provides consultation visits for children with medical complexity that live in our region outside of our immediate primary care catchment area. And then my work is primarily clinical, but I do some research as well, which focuses on the impact of social determinants of health and health equity in this population, and really looking at where medical and social complexity intersect and how to best serve families affected by both.
Wonderful. Thank you so much. Now, one thing we could all agree on is that there is no universally accepted and agreed upon definition of a medically complex child. So let's break this concept down a little bit more. I would love to hear a little bit from each of you, since I know that in your roles and in your institutions, it's really going to vary. But Dr. Wright, I'd love to start with you. If you could briefly sort of define how does your hospital and in your role, how do you define children with medical complexities?
Sure. So we use the definition of children with medical complexity, or CMC, being children with complex chronic conditions that typically involve multiple body systems, often with associated functional impairment and dependence on medical technology. So things like feeding tubes and ventilators. How that actually looks for any individual child can be very individualized, but it tends to have those three features.
Thank you. And Dr. Sonnabend, I'd love to hear from you. Something you discussed was why this concept of chronic disease in general is so complex. Could you talk to that a little bit more?
Sure. I think what Dr. Wright just alluded to is what we traditionally think about as complex patient. And I would love to just sort of throw a little bit of a twist to it. And, the way that I sort of look at a complex patient is someone that requires daily intervention, that requires support from any adult supervisor, whether that's a parent, a community, a school liaison, but it requires daily intervention, sometimes multiple daily interventions a day, that without which would have significant health impairment and health outcome to the patient. And so I think by nature, chronic disease in and of itself, whether it's one ailment or multi-system ailments, fall into that category. And I think that for many years, we've neglected thinking about patients who have chronic disease, morbidities, mortalities into the concept of complex care. And I'd love to sort of challenge us to think about expanding our definition of what a complex care patient is, because of the need for really these services long-term from so many caregivers.
Fantastic. Dr. Freundlich or Dr. Frankel, do you have anything you'd like to add on this sort of definition while we talk about children with medical complexities?
Sure. I agree with what has been said previously. I think that one of the challenges in our field is the variable definitions that are used. It makes it a little bit more difficult for cross comparison and establishing and transferring best practices. But the reason for some of the variable definitions has really come from kind of ground level and local characteristics informing how definitions are constructed. And so I know at my own program, our definition really came up and was built around the infrastructure that exists locally. And that has happened, across the country. So I think this is one of our challenges in the field going forward.
Absolutely. And can you, Dr. Frankel, maybe if you could speak to this, could you shed some light then on how you use the definition of what you and your institution defines as a medically complex child to then inform your institution's approach to care. You especially bring a really unique approach being in the Bronx with a lot of the patients you work with. So I'd love to hear you speak to that.
Yeah, I think we use the same sort of definition that Dr. Wright mentioned, that sort of definitional framework. And for our practice, I would say the only thing we have emphasized as well is that we to make sure that we include children with progressive conditions, because often they are not meeting the definition of medically complex early on in childhood, but may become technology dependent on and all of that. So for us, we end up using this more narrow definition than the one Dr. Sonnabend is maybe advocating for, mostly because in our practice, we have limited resources. So for our practice, we're trying to identify the patients who really need our support, where the general pediatrician in the community is struggling or the parents are struggling. So for now, we've kept it to the most medically complex patients, but we are, as we bring on more people and resources, are trying to expand to include patients who meet a more broad definition. But for now, we're using that pretty narrow one.
You bring up a good point there. I mean, many of our members of the audience come from children's hospitals or pediatric programs with these broader hospitals and health systems. But something you discussed there is working within a resource limited means. And so when you're trying to expand, how do you do that? How can you sort of build that program, build that definition? Do you have any insights you can share as you target that and try to expand?
Well, for me, it's hard. We're figuring it out. I think that Dr. Wright mentioned she does consultative services. That's something we're thinking about. So if we can't actually provide full primary care to as many patients as we'd like to, could we provide at least some consultative services to local pediatricians or in other boroughs or in our surrounding area? For us, it's looking to providers also besides physicians. So we have now 2 nurse practitioners with us, and an RN and a social worker. So having a multidisciplinary team helps to take off some of the load from the medical provider because there's so much else that's going on. And so to take on more patients, like just having 2-3 doctors just doesn't work. You need a full team. So for us, it's building that, and then we'll get into this, I'm sure, but community connections and looking to other people who can support your patients outside of the hospital.
Absolutely. And yes, we'll dive in a little bit more on community care, as well as a little bit later, we're going to get more into social determinants of health. But first, I want to sort of dive into the full family patient experience. And Dr. Wright, this is something you sort of touched on talking about your background. I mean, this is something that really can turn a family upside down when a child is needing this sort of level of care. And how do you, Dr. Wright, I'm going to ask you this one here. How do you approach managing that patient-family experience, especially when there are a lot of siblings involved? Do you have any sort of proven or promising practices that you feel have yielded real results in coordinating care on that level?
Yeah, absolutely. I think, first and foremost, I think it's important for us to keep in mind that patients and their families should really be integrated into the design, implementation, and evaluation of programs that are serving them. And so even when we're thinking about how do we, expand the work that we're doing, how do we serve the population that we're hoping to serve, really involving families in that process can go a long way. We really see parents and caregivers very explicitly as our partners in the care of children with medical complexity. They bring very real expertise and wisdom to their kids' care. And so that partnership with the families is a really big part of our team's model. And I know many other teams use a very similar approach. When we devise things like care plans or do goal setting with families, try to be very focused on function and on aligning with families' priorities so that we're really addressing what's most important to the family, and that patient and family experience piece then just sort of fits right in with that. We do have some formal ways of assessing and gathering that patient and family experience. My hospital has multiple patient family advisory councils. Our complex care clinic has our own, which meets regularly. They provide an important voice and input. And these kind of advisory councils are invaluable. But also, speaking of equity, they only represent a portion of the patients that we serve. So it's really important that we actively seek feedback and understand experiences of the families that we serve through other means. And that direct, clinician patient connection is a great way to do that. And really just having honest conversations with the families that we're lucky enough to take care of. We do also request anonymous feedback from families about their care experiences, as do all the clinics at our institution. And we track those metrics to guide QI work. And then really when we think about, another aspect of the patient and family experience is because of the really complex and delicate web of services, some of which is in healthcare, some of which beyond the children with medical complexity rely on, they sometimes are the first to highlight when there's something going on with the system, when there's something that we need to fix that could affect lots and lots of families. And so helping families elevate their voice and using the sort of channels that we have for talking about patient and family experiences within our hospital has been a way to benefit those families, but also many of the families we serve, even that don't have as many complex needs.
Wonderful, thank you. And Dr. Sonnabend, I want to shift over to you next. One thing that you had shared, or a thought, which I'm sure many of you share, is that really only about 1% of the care for a complex patient occurs inside of a healthcare setting. Yeah. So, having that connection to family or a caregiver is so important. How much more do you feel really needs to be invested in caregiver training and resources and sort of assessing the home environment to see what needs to really be supplemented in order to deliver effective care?
Yeah, I think you hit the nail on the head. That's really where our big gaps are. We've spent historically a lot of effort training providers, clinicians to do really well in supporting patients in an acute care crisis. A lot of focus on training inpatient support, inpatient nursing. And we do a really good job at that universally in the health system. Where our struggle comes in is to what you alluded to, which is that really the majority of care happens outside of the walls that we have direct oversight into. And I think what COVID has done was allowed us to see some of what's happening behind the walls, our ability to do telehealth, our ability to now see inside of homes. For us in diabetes, incredibly important to actually be able to open a refrigerator of a patient's home to see what kind of diet they have. For our ability to really see what type of exercise facilities they have. And then I think even more importantly for families to now see what's happening directly in the schools through their version of being able to see teleeducation. And so I think one of the things that we have to do is really think about a patient as a unit and think about this nest concept, which is really the patient, the family, and then to start to think about the community as the patient have, and to really start to engage and think about caregivers and care education beyond that of just the immediate parents. But for a family that may have multiple complex patients or children within it, the education and the training they need may be a part of the outcomes for all of those children. And we have to take that collectively. So it's really breaking down the silos of saying that this subspecialist works with this patient, whereas a different subspecialist works with this patient. But the underlying uniformity is that an educational need needs to be supported for the parents that support those complex care patients. And so it's really trying to work within a community to say, what is the training that's needed, both at the school level and the community level, working with local organizations. And then what do we need to do in the hospital to engage and to better assess what's happening in the community and what's happening in our patient's home that impacts directly on their outcome. So I love to tell the story that for many years we were doing food insecurity assessments, and I know we'll get to that later. But one of the things that we realized as we talked about diabetes outcomes is the importance of getting insulin. And it wasn't until we started asking the question and seeing what was happening in the home that we realized that this family did not have a refrigerator in order to be able to actually put insulin in the refrigerator, which meant that whatever insulin that we prescribed, which we prescribed plenty of, and they got refilled for, they never had a place to store it. And so then it was constantly expired or ineffective insulin, right? But it was only understanding what was happening at the community level, at the home environment, that allowed us to really target direct outcome for the patient. And so the education that that I think we are really lacking in our system is thinking about outside of what happens within our wall and supporting patients at the home level or at the community level.
Absolutely. And one component to that might be also home care. Dr. Freundlich, I think you work a little bit in that space. If you could talk about consultation and home health care and how that sort of plays into this role.
Absolutely. Yeah, I agree with what has been said, and would just say, even for that narrow definition of the most medically complex children, which is really where our program operates because of resource limitations as well. Even among that group, the amount of time that they spend in hospital is a very small portion of the amount of time that they are living their lives and needing to receive daily care. And so it's, conservatively, I would say we need a huge investment in this home and community-based services space. One of the major problems that we see pre-pandemic as well is in the availability of home health nursing services, which are really needed. And I know this is a national problem. I'm seeing lots of nods. So it was already a major problem, and it's become an even more kind of untenable problem. So I think that if I were pinned down needing to identify one area for focus, that would be it for the patients and families that I serve. It's really, I can't overstate how important the home and community care is for these patients.
Definitely. And how do we, this might be a loaded question here, but how do we bridge that gap? How do you train parents, guardians, and at-home caregivers? And how do you measure and support that healthcare literacy in particular, and sort of bringing that gap together and making sure that you really are working together and supporting that? Dr. Ray, I don't know if you have any comments there, just because you do work so closely with families and siblings, but I'll really open the floor if someone else has any thoughts they'd like to add.
Yeah, absolutely. So much of what was just said resonates with my practice. When we think about sort of caregiver training, or really giving families the tools they need to support their children's health in the place where health actually happens, which is, as has already been said, not so much with us, much more in their home and in the community. It really depends on the family and really building that good relationship with them to really know what is it that they need. There are some sort of obvious ways that we train families, like if a patient has a tracheostomy placed, they get very complex, specific training and supplies for that. But there are other places when we're thinking about things like challenges around medication adherence, or trying to troubleshoot their tube feeding at home. And that's a place where, just like Dr. Sonnabend mentioned, telehealth has been really lovely for families for whom we've been able to use that tool. Because you can see the pump, you can see the meds, we can talk through it together. We can figure out, do we need to come up with a color-coded system? Do we need to do something different? How can we think outside the box to make sure that we are putting all of the pieces together to meet their needs, whether it's a refrigerator or a measuring device for their formula or something else. Health literacy is interesting because we know it's a social determinant of health, and then it can change over time and can worsen with stress. And we know that caregivers of children with medical complexity are under a high degree levels of stress, most, if not all of the time. And so really instead of measuring or sort of assessing for whom it is most relevant, really think about a universal precautions approach for it. So instead of screening for it, saying, everyone benefits from clear communication. How can we make sure that the, written materials that we provide are in appropriately plain language with a low grade level? How do we make sure that we're supplementing with verbal information or visuals, and then using tools like TeachBack to check for understanding when we're communicating with families, because it's humbling how often we learn that we're not as good at communicating as we think that we are. And so always checking with families and never making assumptions about what they got and what they didn't is I think helpful. And then also, we think about, literacy and health literacy are different concepts. And we also see the sort of overlap with when the provider speaks a different language than the family. and how I've found that there are some families for whom the non-English language that they speak at home is the best language for written instruction and everything, and for others it's not. It might not be the right language for writing. It might not be the right language even for healthcare. And so just asking people what works best for them, I think is really helpful. I'm going to stop there because I know there are lots of other thoughts from other people.
Christina, I can just weigh in and give two real examples of, I think, what Dr. Wright is sort of alluding to. But there's been some really amazing data that talked about not only the need for a literacy assessment for every complex care patient, but also numeracy assessments. And so much of what we're doing with medical errors relate to that. And there was an incredible program that took NICU babies and actually put all patients that were there coming to see their child every day and offered them not only an English as a second language course, but also a literacy and numeracy course. And then they looked at the predictive outcomes for those babies whose parents went through that course and those that did not. And there was a tremendous amount of outcome improvement for patients who, once they got the skills for numeracy and literacy, not doing any additional education or any different care, but just looking at their follow-up and years of outcome. And then there was another incredible project that was done looking at chronic disease for asthma. And they found that with doing a home assessment for mold had the biggest predictive outcome for managing asthma and decreasing hospitalization rates for acute asthma exacerbation by being able to do a home assessment for mold and then supporting families and getting mold correction. So those are the things that I think we need to collectively think about. How do we assess patients, but then how do we intervene once we get the information from those assessments, and really pushing us to think about doing that for every disease population as we meet them, because Dr. Wright's right, we miss out on so much and just assuming and making exceptions for where patients are.
Great, thank you, Dr. Sonnabend. I want to, one factor that keeps getting brought up here is the social determinants of health. So I really want to hone in on that a little bit more, and a couple different angles here. First, I want to talk about cost in particular, and cost, how that's handled. And we also have an audience question that I'd like to put in the mix here. So first I have a question, and then I'll get to the audience question. Dr. Frankel, I'm going to start with you because this feels pretty relevant to a lot of the population that you serve. How is cost handled in cases like these, and particularly with families with limited means? And what sort of considerations go into that, not just for the direct care, but also these other expenses, traveling to and from appointments, getting assistance at home? How is that handled exactly?
Yeah, I hope I'm answering this correctly, so stop me if I'm not understanding. But for our patients, so in the Bronx, I think we are still home to the poorest congressional district in the country. So we really do work at the intersection of medically and socially complex. But we are fortunate in New York that Medicaid is quite robust. And so for our patients, all of whom basically qualify for Medicaid, either because of their income or because of their disability, many things are covered. So we are very lucky, like in terms of transportation to appointments. I mean, theoretically, these things are covered and provided. We run into issues all the time. So providers don't realize this, so they don't do the necessary paperwork so that the patient can use those services. The Medicaid taxi wait is more than an hour long. They miss appointments. The taxi doesn't show up. So everything in theory. So I would say we have relatively robust supports there, but our patients and families incur huge amount of excess costs, whether it's like missed days of school, work, like unbelievable amounts of missed work for parents losing jobs because of nurses calling out, nursing shortages. Somebody has to be there to take care of their child who can't go to a typical daycare or babysitter. So, I mean, in terms of, I hope I'm answering your question. It's sort of, I don't have a good answer. Like, this is something we are struggling with every day, how to best support our patients, like trying to find community resources, making sure we're tapping into all of the eligible services, whether it's like WIC program for backup formula, even if the insurance is paying, to be honest. whatever SNAP benefits, things like that, we really see that as part of our care. Like it's not just medical care, but that we need to hook families into all of these services because of all of the added costs of having a child with medical complexities. So it's an imperfect answer, but hopefully speaks to some of the issues.
Well, you raise an important point there that early on you were saying how sometimes this is something providers miss when it comes to paperwork. Is that something you would say? I mean, whose responsibility is that? Would you say this falls in the provider? Would you say this falls in the administration? Is this in medical training? Where would you say is the mark being missed, and where can we better address that?
It's a good question. I'm curious what other people think, but I didn't learn any of it in residency. Like maybe when I was training to be a pediatrician, maybe I got some forms that I asked a supervising doctor to help me with, but I've had to learn it all on the job, whether from other pediatricians, from our social workers, and sometimes from parents who bring me things and say, can you fill this out? But I think that it's our responsibility. It's not the parents' responsibility. Like, how in the world are they supposed to navigate our system? It's so confusing. I can barely do it. So I think it's our responsibility. And then for us, we use the Medicaid health home programs pretty aggressively to help with care management in the community, because those care managers are often able to interface with families very frequently by text message in ways that we can't, and they often know a lot more. So I think learning your local resources is important to help identify the ones that you don't realize, and training the next generation of doctors to know this stuff. It's part of medical care, is this like comprehensive approach, in my opinion.
I can briefly chime in with an example because that definitely resonates with my experience. I was not trained to do any of these things, and I've learned them on the job. And I found that having, I am very privileged to be a part of a multidisciplinary team that has folks like social workers and nurses who have been doing this for a long time and know to ask some of these questions and tap into these resources and know how to help me fill the paperwork out, because it's not always obvious. But one example we see all the time is that in my region, diapers are generally covered by insurance by age 5. And most children who come into my complex care program where I work at or after that age didn't know that, and they didn't have those covered. And so that was one of these like myriad of out-of-pocket costs that families have because the provider they had before didn't know, because it's not general knowledge. And so making sure, one of the first things that we do for new patients, or just at sort of defined time points over time, is identify what are all of the possible resources and how do we tap into them, just like you said, Dr. Frankel. And some of those are for supplies, and some of it is for, waiver funding for more home-based care, which we know there's already a shortage for anyway. But it's sort of saying, what are all of the things we can get for this family? How can we address the fact that the financial challenges associated with caring for a child with medical complexity go way beyond the direct medical bills, and thinking about how helping with getting that refrigerator or getting those diapers can make a difference for families. And then we also use a medical legal partnership to help when needed, when something just is not being covered but is needed for their care. And we've had really good success with that partnership as well.
On that note, in terms of insurance and insurance plans, getting back to the audience question that I'd mentioned earlier, does the definition, sort of as we bounced around a couple different definitions early on, does the definition of a medically complex child relate to insurance plans or access to care? And what purpose does the definition serve? Was the question coming from our audience member. Dr. Wright, if you have any thoughts on that, but if generally anyone would like to chime in to sort of address that audience question.
Yeah, I think it gets back to the beginning of our conversation. We were all talking about how we do or don't share some definitions for the patients that we serve. And a lot of it has to do with resources, right? So similar to some others who have spoken earlier at my hospital, we have a defined set of resources to be able to care for the population. And in some ways, the resources we have for my clinic it's very resource intensive. We have lots and lots of supports. We want to make sure we're delivering those specifically to the kids that need them the most, knowing what other resources are available in the community to make sure that everyone is in the place where they need to be. how does it relate to insurance? So there are some areas where some of these definitions sort of overlap. I wouldn't say that it informs how we come up with this definition for ourselves, but for instance, for children who are eligible for home-based care like home nursing, a lot of those same categories need to be met of having specific types of medical technology dependence, needing that constant care by someone with medical training like a nurse. And those tend to be children who would be part of this population. And similarly, some of the other supports like medical like durable medical equipment that we help provide for children. Because our team includes folks who specialize in that, we want to make sure the kids that we're serving are those who need those things. So for us, and I'd love to hear others' thoughts as well, they're not directly related, but I think they both sort of reflect a very high needs population with a certain type of acuity, and so sort of similar chronic types of needs, though each child is very individual.
I would just add that I think one of the challenges we have and why insurance and cost comes into such play is that we are still living sort of in a world divided. Half of us work in academic centers that are still traditionally in sort of a fee-for-service model, where you are financially potentially incentivized or hospital incentivized to have hospital admissions and to have acute care visits. And then the other half of us spend some time dabbling in sort of a value-based proposition. And certainly I'm a bit biased in saying that I think that getting towards a value-based program and looking at really bundled payment programs is our way out of really linking high complexity with cost and access. And I do think that they're directly related. And I think that's why these definitions play such a big role. We spend a lot of our time as clinicians arguing to get services for patients. And that's a lot of the clinical documentation. What I'd love to move us towards is a world where we argue why we don't need services for patients because we've been able to do the preventative care that we want to do. And I think that's going to take a lot of work on us as clinicians to lead by developing strong business cases, return on investment models that really show where predictive and preventative care is so monumentally important at reversing the course of some of these outcomes and supporting patients in a more holistic fashion. So when we talk about parents miss days of school, when we talk about kids or parents miss days of work, kids miss days of schools, the amount of nursing support is needed in the home. These are all really costly services. But if we can show improved outcomes, and we've been incredibly successful locally on the level to do that and partner with our insurance companies and develop value-based propositions and proposals that allow us to really put at the forefront patient-directed outcome and leveraging these services and getting away from, spending the time needed to do these clinical documentation, which take and consume a tremendous amount of care. And I think that it falls on everyone. There's no allied care worker that's not spending their time doing this work. But I really hope, and maybe I'm overly optimistic, that our solution going forward is to reframe the cost structure within medicine and how we look at supporting patients.
Dr. Freundlich, did you have something to add?
Well, I was just going to say, as far as the insurance question, it may be more front of mind here in Tennessee, where we have only recently had a Katie Beckett waiver. We were the 50th state in the nation to adopt a Katie Beckett waiver, but that is one, I think, frame in which meeting a definition of medical complexity allows a child to qualify for Medicaid independent of family income. And so that would be kind of one concrete area of definition where it is tied to insurance and to access.
Great, thank you. I'd like to kind of use that to transition a little bit into first an audience question here, and then generally talk about some policy and advocacy solutions. So this question actually comes from a parent of a medically fragile child. And they say, one of the biggest gaps in my child's care happens in the school system, which a few of you have talked about, especially since COVID started. The school is not staffed sufficiently to safely care for him. How can I or my child's provider advocate for his medical care at school? Currently, he's not getting educated in the way he needs because his medical procedures are not getting done at school. I know, Dr. Wright, you do quite a bit with family advocacy, but I don't want to pick on you there. If anyone has any thoughts they'd like to weigh in here, I've heard a couple of you speak to that on missing school.
Yeah, I'm happy to speak to it briefly and sort of thinking about, some tools for educational advocacy for kids with complex needs. We think about for any child age 3 and older, so much of, learning and therapies happen in the school setting. And so it's really important to have that be as successful as possible. One thing that I found helpful in my practice is that for children who are getting therapies at school, that's typically through an IEP or an individualized education program, and that has to be renewed every year or more often if needed. And at that meeting, where all of the folks who help put together that IEP document are there, including a parent, a pediatrician or someone from the primary care or whoever the best medical home is for that child can be there, can be a part of it. And so that's something that our team does frequently, is participates in those meetings, reviews the IEP once it's been made before the parent signs it, to make sure that the plan that's there reflects what the child's needs are. It is true that many school districts don't have as many resources as they would like, or any of us would like, to be able to meet the needs of all the kids that they serve. And so, having that additional advocacy voice from a medical team as a part of that process doesn't necessarily change that, but can help to make sure that the school really has a good understanding of your child's overall needs. Many states and communities also have nonprofit, often parent-led organizations that are designed to help with advocacy, to really help you find the right language that you need when you're trying to talk with schools and sort of push the process along, to really understand the legal framework of it, of how long schools have to go through each step of the way. I found that in general, schools really are trying to do a good job and really are trying to do right by the kids that they serve. And they just don't always have everything they need to do that. And so helping them stay accountable to the process and being in good communication can be helpful with that. Beyond that, sort of thinking about for our kids that have really extended lengths of time that they're away from school, thinking about other sort of educational models can also be possible. Something that some of my patients utilize is like home care and homebound, instruction, where for the flu season or after a big surgery, or even for longer terms, getting some of those services in the home or in a different structure allows them to keep working towards those learning and therapy goals without having those interruptions of long stretches out of school.
Great, thank you for that. And I want to talk a little more broadly in terms of some policy solutions to address here. Dr. Sonnabend, I know you have a lot to talk on here. Are there any policy solutions that you all have worked on at your institution, either at the state, federal, local levels, that would really help children with medical complexities? Could you share some examples of those efforts?
Sure. So, when about 10 years ago, we launched into really a population health approach for chronic disease management and several disease. And I got involved because we launched one in diabetes, and that was the division that I sort of oversaw. And without those quality initiatives have really grown significantly. And one of the things that I think we had an incredible vision that from the beginning is to really divide those care process teams, we call them, into having a real focus on community, and in community to really have a focus on advocacy work. Texas was a state, it sounds like very similar to Tennessee, where Medicaid coverage for technology for diabetes care, that includes continuous glucose monitors or insulin pumps, which are really the mainstay of therapy and have tremendous data supporting that correlated with outcomes, were not approved. And so one of the things that our community team really focused on was in partnering with local vendors, local insurance companies, and really putting together a team approach to advocacy work that was done at the state level. And so several years ago, we all celebrated that we were able to overturn that decision and get Medicaid approval for technology support to equalize that for commercial payers. And I think part of the way that we've done that is to be able to support these initiatives with profound data. I think one of the things that we notice is that we as a healthcare system typically are the collectors of that data. We have the information, that makes very difficult for patient advocacy groups or for even industry advocacy groups to really be able to do that at the legislative level. And so in partnership, what we bring to the table is this wealth of knowledge and data related to what the inequity of care looks like if without that financial support or insurance coverage. And so it allows us to be able to really partner together to really win some, what I would say, incredibly challenging obstacles. And we've seen tremendous improvement in outcome related to that advocacy work. So I would really encourage, I think, those of you who are interested in this line of work to really find a way to partner from both bringing in insurance groups, patient advocacy voices in the community, as well as the healthcare systems to the table to do this in joint efforts.
Where would you, I'm sure you've got some wheels turning in the audience here among clinicians. Where would you even recommend to begin? What sort of advice do you have to start building those partnerships? Where to look, who to look for, and how to begin those outreach and partnership efforts?
Yeah, so one of the things that really helped us was working with our government relations office and really trying to understand what was coming up on the legislative docket for every session, and then truly trying to understand how those laws or those voices and where we could really put in. So what we spent a lot of time was in writing campaigns, and then also in getting signatures from large patient populations and community workers to really support overturning some of these decisions. So I would start with your own local government relations program. If you're in an academic center, they have, I think, a really good lens of what's happening and what's in the future horizon, and really going and looking through some of the bylaws, which are very lengthy, and really take very much a legal framework and background to peruse, but and really looking and seeing where there are opportunities to advocate. But that would be the first thing that I would probably recommend doing as a clinician.
Wonderful, thank you. We touched on this a little bit earlier, but I want to circle back and really address COVID-19 and sort of the impacts that the pandemic has had on this patient population, both really in the short term and in the long term. And Dr. Freundlich, I want to start with you because you particularly talked about staffing in terms of home health aides and nurses in particular. So I'd love to hear from you sort of how you're addressing that shortage and what you sort of anticipate for the more long-term or medium and long-term, kind of what your outlook is here and how you're addressing that.
Absolutely. So I mentioned that home-based services and home health nursing in particular was a difficult kind of area even pre-pandemic. And then the pandemic introduced a number of factors that really have affected workforce shortages across many sectors, but particularly in healthcare. This, was a group of workers who are impacted by family health needs of their own and by closures of daycare and schools, as well as personal risk and assessment of personal risk with the spread of COVID-19. And so, certainly there was a dramatic impact and a sort of a dramatic and fairly immediate impact in the availability of home health care at the beginning of the pandemic. And I think it still remains to be seen what the long-term impact will be. But what we feel on the ground is that those shortages are still more significant than they were pre-pandemic, where they were already a problem. And we already knew from research that patients who need home health nursing services in order to discharge from the hospital have a fairly significant median length of additional stay because of that. So I think, though, that there is hope. There are some novel approaches that can be taken. The state of Colorado, for example, has a paid parental certified nurse assistant program. It's not a comprehensive solution, but a piece of the puzzle to address both workforce shortages as well as the financial burdens faced by families providing their own care, and can be a good fit for some families where that's like a preferential model. But I think that this is still certainly, remains to be seen and really requires our attention to address.
Thank you. And beyond that, beyond the staffing issues, we're really just starting to see a lot of these long tail impacts of COVID. Dr. Frankel, I'll start with you. How great is your concern, particularly within your communities, about the impact of chronic care management? How has that sort of impacted you now, especially in terms of reaching your patient population? And what concerns do you have moving forward from some of the impacts you've maybe seen so far?
I think, at the peak in New York, obviously it was quite horrific, and it took a long time for us to get our patients comfortable and families comfortable coming back to visits in person. And then having a spike again in Omicron in, I guess, around Christmas in January in New York was quite bad again. And we were having nursing shortages and stuff in the hospital because of deployments and people were sick. And so again, parents were nervous about coming back. So we've done a lot of work to try to get people to come in person. And so that's gotten somewhat better, but that's a bit still an issue. Vaccination is where we're trying to put a lot of our efforts. In New York, you can get vaccinated at home if you are homebound technically. So many of our patients qualify for that, which has helped us. I think in terms of like the long-term aspects, it's hard to say and hard to predict. Most of our patients have started to come back to regular care, which is a good thing. And most of our patients have also returned to school, because that is the other place that, as the parent mentioned, like school has been a major issue for us to get appropriate staffing and therapies. And in New York this year, there was no remote option. So kids either had to go to school or home instruction is like an hour online. So it's really not an adequate replacement. So that is where we're seeing probably the lasting impact of, besides from the home nursing shortages and home attendant shortages, also appropriate staffing, like that parent mentioned, for kids to go to school safely. So I think that is actually probably my biggest concern, because that's, as other people have mentioned, where our patients get so much of their daily care is at school. And they have a federal, they have a right to go to school in the least restrictive environment and all of that. So I do worry about that long term from COVID.
Yeah, I would just maybe add that I think one of the things that we're seeing as a long-term or tail effect of COVID is the behavioral health impact that it's had on both caregivers and patients, and staff that care for patients. I think both in the health industry, but also in the school industry. And it's been incredibly taxing, I think, for everyone. And what we're seeing is maybe a slight improvement in that as kids are returning back to school, as people are returning back into the workforce, and some of that social isolation is decreasing. But it is a profound impact, and I think really addresses the fact that we need to collectively start assessing the behavioral health component, because it is so intricately a part of really what impacts outcomes for complex patients. The other part I think that we're going to see, and I think that the data is only starting to come in, is really what the educational deficiencies that have come from so many people being out of school settings. And we are seeing, and I think certainly the teachers have been describing this, kids who are entering high school who are really coming in at the level of an elementary school, both psychologically, both from a maturity level, and then certainly in their educational level. And so there's a lot of catch up that we're having to do. And it changes how we educate and how we interact with patients in those age groups. And we have to reshift and refocus what the educational materials that we're developing and the programs that we have for patients and really meet them where they are. So again, I can't stress enough the importance of really assessing patients and then doing something about it, because assessing is never enough. That's only really the tip of the iceberg. But if you don't assess, then you don't know where the gaps are, and then you don't know how to intervene. And the part that we're really good at as clinicians is intervening, but we've got to know what we're starting with.
I want to just quickly add to what Dr. Frankel was saying about vaccination. When you think about like, we're good at intervening, right? What can we do with all of these services that we don't have a lot of control over? And I think with caring for this population, being able to talk with families about vaccination and provide that really good pediatrician or medical provider voice to give good evidence-based vaccination advice, I think is a place where our skills are really useful. And vaccination really is, I think, our best defense when you think about the long-term effects of COVID infection itself. Obviously, the COVID pandemic has done a number on a lot of other things, but for COVID infection itself, that's a place where we really do have something we can do.
Thank you. I'm sure we could, do a whole part 2 session just talking about this topic alone. But we're coming down in the last couple of minutes here. So I just want to open the floor up if there are any sort of final thoughts or takeaway lessons, either for parents or individuals, clinicians or children's hospitals that maybe we haven't covered or you'd really like to sort of drive home here. I'll open it up here. The floor is yours if anyone would like to hop in.
I'm happy to share. I think for parents and caregivers of children with medical complexity, one of the really, simple but important things that you can do is to share your story and share it broadly, because there are lots of people in society who are very unfamiliar with children with medical complexity and the lives that they and their families lead. And your stories are powerful, and they can change minds and hearts to kind of build more of a groundswell towards action on some of these important issues.
Excellent. That's fantastic advice. Thank you.
I would just encourage, I think, all of us to take a population health mindset and to really think about it beyond sort of at the patient, physician, or patient provider level, but to really think collectively about our entire population of kids who struggle and who require significant interventions that they cannot do on their own. And to really think about how do we collect the data on this? How do we build robust infrastructure and informatics, data analytics that really allow us to progress through a data maturity model of not just reporting on these outcomes or reporting on populations, but from really being able to then move into prescriptive analytics and predictive analytics that allow us to put resources, those very few resources, very costly resources, to the right care, to the right patient, to the right time, and really building these predictive models that allow us to really look to see who's at risk for an adverse event, and to put those resources collectively in that. And I'm a big proponent of saying that it's going to take us all moving to these platforms to really build these robust data analytics that allow us to do this sort of work. And the places that have been successful at doing that are starting to show really outcome improvement for not just an individual patient, but really at a population level. And that's going to change our value-based propositions for how we get care and coverage services, and then how we provide access to patients, and hopefully how we change the outcome in the course of these patients' lives and the families' lives.
Wonderful. Well, thank you so much to our panelists, Dr. Freundlich, Dr. Sonovan, and Dr. Wright, for joining us today and sharing your insights. This was a really fascinating conversation.
Thank you.
This webinar, it's part of our summer-long children's health series, Pediatric Priorities, Improving Children's Health. Next month, we'll be discussing vaccine breakthroughs while combating disinformation and skepticism, as well as community partnerships for child health. So we hope you will join us. You can learn more at usnews.com/events. And thank you for tuning in.